but you can see there was about a 20% decrease in fracture and actually a 12% decrease in mortality. The 12% decrease wasn't significant. But still, it just shows you what you can do over the course of 5 years. And so the conclusion here is that 4 monthly supplements with 100,000 units did decrease fracture risk without any adverse events in men and women. So that was a really interesting example. So what are the efficiencies here? Well, number one, in that study, there were basically no selection criteria. I mean, you didn't screen out for history of kidney disease or cancer, so it's very, very broad. There were no follow-up clinic visits or measurements, no follow-up labs or measurements, and the outcomes were self-assessed by mail-in. So it's a whole different beast than the kinds of trials you typically see. And in terms of cost, it's very efficient. And these sort of can't compare, they're apples and oranges, but this vitamin D trial cost roughly $500,000, which is fairly amazing for a 5-year trial of several thousand people. And by comparison, the cost of the Women's Health Initiative, maybe sort of at the other end of the extreme, was about $1 billion. So, which used to sound like a lot of money, but now they kind of toss that out every day to give more than that to your favorite bank. But anyway, it used to be a lot of money. And again, so large and simple trials, if you can figure out some way to do it, and some interventions are amenable to it, it's something to be considered. Okay. So that's sort of about trial design and frequency of follow-up measurements. Yeah?
It seems, though, for the large and simple, if there really are not going to be selection criteria besides age, you really can't test an intervention that's risky at all.
Yes. I think, yeah, that's a good point. Right. So the kinds of things you can do, yeah. I mean, the problem is the safety assessment isn't done very carefully. So if, for example, you had a patient who took a pill and had some horrible side effect, and you wouldn't, it's harder to know about it. So you're right, the kinds of things that it's better for would be things like, vitamins, maybe some kind of behavioral interventions you might be able to do that way, herb supplements, things that but you have to be fairly confident that they're safe. Yeah, I would agree. And also things that you can distribute kind of by mail. So obviously, if you're doing a study of, for example, an injectable drug, it'd be very, very difficult to do that by mail. Okay. So, we'll go on and talk about adherence and compliance. Okay, or compliance. The adherence is sort of the more politically correct term. Compliance kind of implies that you're kind of forcing someone. So, but the trial is meaningless unless participants adhere to the interventions. You can get randomized people to active or placebo. If nobody takes what they're supposed to take, the trial is meaningless. But I think when you're thinking about adherence, you need to really think carefully about it, because people use it kind of in an ambiguous way. For example, you often read papers and they say there were dropouts. There were 10% dropouts. What does that mean? Because it can mean all kinds of different things. So I think it's important to kind of keep in your head that adherence really has several different aspects. And one is that adherence to the medications or the intervention. In other words, do people actually take the pills, or do people actually do the exercise program, whatever it is. And that would apply to the placebos as well. The people who are not supposed to take medications don't. So, for example, if you're doing a study of aspirin or placebo, adherence to placebo would include not taking, aspirin out of the bottle. And then another aspect is adherence to visit schedules or reporting. So, for example, if someone just doesn't come in to a visit, you don't know what their value is. There's a lot of missing data. If data say heart disease was your outcome, and you just didn't know whether they have it, that's missing data. And so that's another aspect of adherence. And then there's another aspect which you could say is adherence to the protocol. For example, how well does the clinic adhere to the protocol? So if the protocol says we should only admit people over 60 who have blood pressure, systolic pressure, say greater than 160, if you get all done with the trial and you find out, oh, we have people in here 57 whose systolic was only 140, that wasn't adherent to the protocol. And then there are aspects of that in follow-up, when the follow-up visits occur, et cetera, et cetera. So these are sort of three different aspects. They're obviously related. But I think it's important when you're reading about a trial to keep these in mind that they might be reported separately. So what does lack of adherence lead to? Well, there can be bias, strong bias. I'll show you a couple of examples in either efficacy or safety. You can imagine, for example, if you're giving a treatment and it's fatal, people die and you don't know about it, and you say, well, we had 10% not followed up in the active group, and it turns out they all had bad outcome. So that could clearly be a bias. There can be decreased power if you have decreased adherence, and in the worst case, the results are just uninterpretable. And it's particularly the second point, the decreased power, is particularly important because you get all done. Let's say you find no effect of your intervention. And you say, well, why is that? Is that because the intervention doesn't work or because people didn't take it? And I showed you the vitamin D trial, and that's kind of a best case vitamin D trial. After that trial, there have been a whole slew of other vitamin D trials, and most of those have not shown positive results. And generally, when you look at the papers, they say, well, the adherence was 60%, or a lot of the people on placebo were out taking. Went out and bought vitamin D because we told them about it in the trial. So it's really an important factor, and particularly if you're looking at a negative trial, a negative result trial, you might want to ask what the adherence was. So what's the goal? The goal in having adherent data would be to get the primary outcome, to have all the people participate in the study, and to get at least the primary outcome from everybody randomized. And that's kind of like keep your eye on the prize. It's like a lot of times people get lost. They say, well, what am I trying to do here? But that's really the key thing. Generally, you have a primary outcome, and if you have to sacrifice a lot of other things along the way, if you can keep that's good. That'll be good for your trial. What are some of the techniques to assure complete follow-up for the primary outcome? And this is kind of under the assumption that you're having some problems. Somewhere along the way, people are starting to get tired of your study, whatever. What can you do to kind of try to assure? And so the one thing I would say, you tell people, well, if you can't come to any visit, can you at least come to the closeout visit where we're going to assess the primary outcome? We're going to find out whether you had a heart attack, or we're going to measure your blood pressure that final time. Even if you've missed other visits. And a lot of times in trials, there are trials that are done in different places, for example, they'll often really go to fairly extreme measures to get people into a final visit. For example, if you're doing a multi-center trial, you might, or even a single-center trial, but if people moved and they're not on the trial anymore, you might actually fly them in just for this visit. And I've been involved in studies that do that. If you're having a multi-center trial, maybe you have a center in San Francisco and another one in Phoenix, and maybe your participants have moved to Arizona, so they could maybe be seen for follow-up at that other clinic more conveniently to where they live. You could possibly get the outcome by telephone, maybe use a surrogate contact if a person, say, has gone into a nursing home and can't respond. Maybe their son or their daughter could be a surrogate contact that could tell you about whether they've had the outcome you're looking at. And then possibly consider using external data sources. So there's something called the National Death Index, where if you have the person's Social Security number, eventually, this takes a year or two, but eventually you can get whether or not they died. And again, Medicare, Kaiser, things like that. Well, let's talk about this a little more. Okay, so missing data for the primary endpoint. Why might you have that? Well, that may be a result of loss to follow-up, or it may be other reasons. And how can it lead to bias? Well, it can lead to bias, especially when the loss to follow-up varies by treatment. For example, if the people in the treated group drop out more than the placebo. And why would that be? Well, you can see right off that you've started by randomizing. You say these two groups are really similar, but if you lose 10% of one group, these two groups are then no longer similar. And that would be usually the case. In this loss, for example, the people who drop out of studies tend to not be a random sample of the people in the studies. So you tend to lose the older people. Sometimes you might lose the younger people who are like employed and they get tired of coming to clinic visits. But generally you get people who are sicker will be lost. So you definitely have a bias in the kinds of people that get lost. So you really want to try to minimize that loss. And I have kind of this cooked up example that shows you that even in certain cases,